Hello, I'm Howard Gurney, the Director of the Clinical Trials Unit at Macquarie University, and I'm going to give you a crash course in the basics of response evaluation criteria in solid tumours, otherwise known as RECIST 1.1. So a few decades ago, we used to determine response by measuring all of the lesions on scans and giving them bidimensional two measurements and adding all those lesions up. But in 2000, there was a simplified where again, all the lesions were measured, but we only measured things in one dimension. And then in 2009, this was further simplified in the RECIST 1.1 scheme, where the number of lesions that you actually measure was limited, which we'll talk about. And there are also other rules for such as measuring lesions in lymph nodes and in bones. So central to RECIST 1.1 is the concept of target and non-target lesions. So put simply, target lesions are something that can be measured, and non-target lesions are those that can't be measured, such as a pleural effusion, or can be measured, but you haven't selected it as a target lesion. So we'll talk about that in a sec. But RECIST 1.1, importantly, it limits the number of target lesions, so a maximum of 2 lesions per organ, and a maximum of 5 lesions total. So lymph nodes and lesions that are not in lymph nodes, such as in the lung or the liver, they're measured differently. So for non-lymph node lesions, you measure the longest axis. And if you're re-measuring it later, again, you use the longest axis, even if the thing changes shape. So for lymph nodes, the shortest axis is measured. And for non-lymph node lesions, such as a lung lesion, they have to be at least 10 millimeters. Lymph nodes are a bit harder. So if the lymph node is going to be a target lesion, then it has to be at least 15 millimeters in size. Normal lymph nodes are less than 10 millimeters, so that's normal. So lesions that are between 10 to 15 millimeters, they're abnormal, but they're too small to be used as a target measurement. So here's a CT scan showing an enlarged lymph node. We want to measure that, and we know we have to measure the shortest axis, which is probably going to be sort of here somewhere. So how do we do that? So you take the longest diameter, and then you take the longest perpendicular diameter, which is that one there, and that we call as the shortest diameter, or another way of putting it, in this case it's 21 millimeters, but it's the longest shortest diameter. So in this case it's 21 millimeters. So remember, it has to be greater than 15 millimeters to be a target, and non-target but abnormal is 10 to 15 millimeters. So here's a lung lesion, so it's not a lymph node, so you measure the longest axis. But you can see this is an unusual shape, so you wouldn't really pick this one as a target lesion if you can, unless it was the only lesion available, because you could easily, it's hard to reproduce the measurements. So there's a little tongue of tissue coming off here, and you'll get different images, and sometimes it'll show and sometimes it wouldn't. So you still need to measure the longest diameter, but you probably wouldn't pick that one as a target lesion if you had other ones available. So when you're using CT scans, you always use the axial plane, which is this one. So you don't use the sagittal plane or the coronal. This is the coronal plane to measure. You must use the sagittal. Okay, here's a quick test. So see if you can select all the correct answers here. So they're either true or they're false. So regarding target lesions, I'll give you a few moments to go through those in your own mind. Okay, so how did you go? Here are all the answers. So regarding target lesions, the maximum number of lesions total is 5, not 7. but there are a maximum of 2 lesions per organ. So regarding lymph nodes, all of the lymph nodes are considered as one organ. So if you've got lymph nodes in your neck, abdomen, and groin, they're all considered one organ. So you can't choose more than 2 of those as target lesions. So you do measure the shortest diameter for lymph nodes. You do measure the longest diameter for non-lymph node lesions such as lung, liver lesions. And measurements on the CT scan all must be done on the axial plane. So next is the concept of sum of diameters. This is simply the sum of the diameters of all the target lesions. And this is a simplistic representation of the bulk of the cancer that's present. So here we have 3 liver lesions, but you remember you can only choose 2 of them as target lesions for RECIST. So you choose those 2, you measure the longest diameter, and you add those up. So in this case, it's 20 plus 30 millimeters is 50 millimeters. So 50 millimeters is the sum of the diameters, because you're going to use this later to work out whether the cancer is growing or shrinking as per RECIST. And remember, lymph nodes use the shortest axis. Bones. Bone lesions you don't tend to use as measurable lesions. You can't use them as target lesions. They're not measurable. This is because the lesions don't really change in shape or size, even if the cancer shrinks up. So it doesn't give you a good representation of what's happening with the cancer. But you can see the lesion on the right-hand side there. It has a large soft tissue lesion that's visible, and that can be measured, and it can be used as a target lesion. So in summary, you have measurable and you have non-measurable lesions. Non-measurable such as ascites, pleural fluid, indistinct changes in the lung, and then you have measurable lesions which can either be target lesions or non-target lesions. Target lesions, again, only 5 in total, maximum 2 per organ. Lymph nodes are considered as one organ. And then all the other measurable lesions, which you haven't selected as a target lesion, are non-target lesions. So we have, and it's only the target lesions that go towards this sum of diameters. So even though these non-target measurable lesions and the non-measurable lesions, they're all non-target lesions, so you don't actually have to measure them. You just have to say whether they're present or whether they're absent. So let's talk about response assessment. So to work out whether whether a drug is working on a clinical trial, you need to assess whether the cancer is growing smaller or it's growing. And then, so RECIST 1.1 is this simple and reproducible method for categorizing response. So it can be used all throughout the world in different units, all taking part on the same trial. So complete response is easy. So that means everything that looks like cancer has disappeared on the scans, both target and non-target lesions. Partial response is where there's at least a 30% decrease in the sum of the diameters. And this is in reference to the baseline scans. Progressive disease is where there's a 20% increase in the sum of diameters, in this case from the smallest, from the nadir. So you don't compare it with the baseline. There's this additional rule in RECIST 1.1 where the sum of diameters, all the diameters, has to be at least 5 millimeters. So this is to stop minor changes in the tumour size, being called PD, when the cancer is small. So such as this example here where you've got a solitary lymph node. Or with progressive disease, you can have unequivocal new lesions. And a stable disease is whether it's neither PR or PD. So confirmation of response is required on some studies, particularly phase 2 studies, but that's when response is the primary endpoint of the study. And in that case, you need to do another scan, usually 4 weeks later, to confirm the response. But then we have this overall response. So it's not just target lesions that we're measuring. We're looking at the target lesions, the non-target lesions, and also whether there's any new lesions. So, for example, you could have the target lesions have still small, but you get new lesions developing, and that's progression. Or you might have an increase in the non-target lesions, an unequivocal increase in all the pleural effusions, or the non-measurable, the measurable non-target lesions increasing in size, and that also can be called progressive disease. New lesions, they need to be unequivocally due to cancer and not some other pathology. And if the investigator or the radiologist is not sure, it's okay to say that they're not new lesions and keep watching them. But of course, if they grow subsequently and you think, oh yes, hang on, it is cancer, it is progressive disease, then you backdate to that first scan where you first saw the lesion, where you were uncertain as to whether it was cancer or not. So here's an example of a complete remission in a lymph node. So the node here has reduced to 8 millimeters in size. Remember, anything less than 10 millimeters is considered normal for a lymph node. So in this case, the actual size, in other words 8 millimeters, is recorded in the ECRF, not 0 millimeters. But if this is the only lesion, even though you've recorded 8 millimeters, you can still call it a complete response. So here's a real example, measuring the shortest diameter of the lesion here. Again, you get the longest diameter and you get the longest perpendicular diameter. In this case, it's 20 millimeters. And later on, the longest, the shortest axis is 9 millimeters. So, but you record 9 millimeters, not 0 millimeters. And again, if that's the only lesion you got, you can call that a complete remission. Okay, let's go through an example. So here we go. We've got 2 liver lesions and 1 lymph node lesion, and you've got the baseline measurements and you've got the lesions now, and you have to work out what the percentage change is. This is how we work out whether there's a response or not. So you use this formula. You get the sum. Here's the baseline sum, and here's the sum of the diameters now, and it's the difference. So the sum now minus the sum at baseline divided by the sum at baseline times 100, and there's the calculations there, and you can see that it's reduced in size by 44%. So that's a greater than 30% reduction, and therefore it's a partial remission. Partial response. Here we have a change where the lymph node reduces in size to 9. You record it as a 9, don't record it as a 0, even though that's the smallest diameter. It's still a partial response. Here, the other lesions have disappeared. The liver lesions have disappeared completely, and the smallest lesion is 9. The lymph node is 9, the smallest diameter. You still record it as 9, but you can record it as a complete response. Now, here's a lesion that appears to be getting bigger. The sum of diameters now is 88. The smallest was 55. The comparison is now made with this nadir. You don't make the comparison with the baseline. So the sum now minus the sum at nadir divided by the sum at nadir times 100 is a 54% increase, so it's greater than 20% increase, so that's progressive disease. Here we have a response assessment in a solitary lung lesion. So there's an initial more than 30% reduction, so that's called a partial remission. You get another few lesions which are a bit smaller, but it's not complete remission, so they're called still partial remission. So between here and here, this is still a partial remission. It's not called stable disease. So the response is still partial remission. And then we get a slight increase, so that's not a 20% increase, so it's still called a partial remission. It's not stable disease or PD. So now here's the trick. You get a further small increase. So it is a 20% increase. So actually in RECIST, 1.0, this was called PD. But in RECIST 1.1, because the sum of diameters hasn't increased by more than 5, 10 to 13, 10 was the nadir, 13, it's actually still called PR. And if you get a further increase here, 10 to 16, that's more than 20% increase and 5 millimeters. So that's now unequivocally progressive disease. So that's the date of progression. That's very important for the duration of response and progression-free survival. So in summary for the baseline, choose the target lesions. They need to be measurable, 2 per organ, 5 in total. Non-lymph node lesions have to be greater than 10 millimeters. Lymph nodes to be target lesions have to be greater than 15 millimeters. You calculate those sum of diameters, nodes using short axis, non-nodes using the long axis, and the non-target lesions are everything else that is cancer, measurable or non-measurable, and you just have to say whether they're present or not, and you've got to make sure that they really are cancer and not something else. For response, CR, everything goes away. Just remember, lymph nodes can still be present, but less than 10 millimeters. PR, 30% reduction in the sum compared to baseline. PD, 20% increase in the sum of diameters compared to the nadir, not the baseline. Or if new cancer lesions are present, remember the 5 millimeter rule. Stable disease, it's not CR, PD or CR. And if response is the main endpoint, such as a phase 2 study, you may need to do a confirmatory scan 4 weeks later. Okay, let's go through this worksheet example. So we've got some lesions in the liver, number of lesions in the liver, some in the lymph nodes, 1 in the lung. We've got 5 in total, 2 per organ, everything's looking good. All the rest you put as non-target lesion, and they're present at baseline. And their sum is 195 millimeters. In week 8, there we have the appropriate diameters, longest diameter for liver and lung, and shortest diameter for lymph nodes, and the sum of diameters is 95. So can you please calculate that percentage change using that formula? I'll give you a few seconds. Okay, so if you calculated it correctly, there's the calculation there. It has reduced in size by 51%, so we can call that a partial remission. Time goes on, we go to the week 12 scan, where the liver lesions are resolved, the lung lesions are resolved. You've got lymph nodes that are measuring 8 and 9. So you've got the sum of the diameters are 18 millimeters, 17 millimeters. Measured that incorrectly. What is the response assessment? Okay, if you've been listening, you know that this is a complete remission because the lymph nodes are less than 10 millimeters and all the other lesions have gone away. So that's a CR. Time goes on. Week 16. Some of the liver lesions are growing again, as are the lung lesions. In fact, all the lymph nodes, all the lesions are growing. The non-target lesions remain absent, and you have the sum of the diameters there of 64 millimeters. So what is the percentage change? While you're doing it, I'll give you a clue. Remember, you're looking at the nadir now, the change from the nadir, not from the baseline. And if you work that out correctly, there has been a 255% increase. So that's a greater than 20% increase. So that is a progressive disease. So as extra question, what's the confirmed best overall response? Confirmed best overall response. Trick question. So it needs to be repeated at least 4 weeks later. So the confirmed best overall response is partial remission, because you don't have a confirmed CR here. But if you don't need a confirmation, you don't need a confirmatory response, the best overall response is CR. Okay, so that brings us to the end of that crash course in RECIST 1.1. I hope you found it